Think we're about ready to get started. Can you guys hear me okay?
Yes.
Great. All right, we'll jump right in. We got kind of a light crowd this morning, but maybe people will be joining us as we get going. So today, just kind of continue on in kind of our general internal medicine kind of lecture series that I've been doing for a while. And I thought it would be fun to, rather than just kind of look at ultrasound in an isolated way, would go ahead and kind of look at kind of an integration in an approach to a dyspneic patient, where kind of all of our procedural modalities that we use as generalists can be kind of put to use, so to speak. So I wanted to just start with introducing a case, and then we'll proceed through looking kind of indirectly or actually directly at how to look at a pulmonary function test, indirectly at EKGs, which you guys have been working on a lot. So I'm going to gloss over that quickly. And then semi-directly at the concept behind POCUS, and then use pulmonary function EKG POCUS in the setting of history and physical to try to sort out this particular case. And so I'll share this case initially. We'll dive into the teaching part, and then we'll come back around to try to put this all together. So here's our case. 82-year-old female presents as a new patient to your outpatient clinic complaining of worsening dyspnea for more than 6 months. So standard bread and butter, very common. In breaking it down, I'm just trying to keep it simple to focus on these points. And oftentimes, new patients can be simple as well as complex. But past medical history, family history, social history, review of systems, all negative. Vitals are normal, with the exception of on room air, she's satting 89%, but comfortable. Physical exam is significant for bibasilar crackles, systolic murmur, diastolic murmur, and 2+ lower extremity edema. So keep this case in the back of your mind as we kind of move through some of the teaching points here, because we're going to come back to it at the end. So as we begin to kind of try to objectify this subjective presentation of dyspnea, very common presentation. I mean, this is the role of the generalist. This is what makes general internal medicine fun, is when we get a chance to take kind of the undefined, the indeterminate, the unclear, and try to pull it together in a way and in a perspective that brings us to a diagnostic, or at least a list of a good differential diagnosis and then treatment options. So in the dyspneic patient, in addition to our history and physical, what are some tools we can use? Well, pulmonary function tests, spirometry. Office spirometry generally doesn't include the actual measurements of total lung capacity and residual volume. So that's why I put spiro in parentheses. But oftentimes when we order PFTs, we do get the full amount of data. So PFTs, EKG, point of care ultrasound, treadmill exercise test. These are all nice tools we have at our disposal, in addition to the history and physical, to answer this burning question that how often does this come up? Multiple times a day. Is this heart? Is it lungs? Is it deconditioning? Or is it something else? And so let's look first at pulmonary function tests. And actually the majority of what we'll be talking about in using these modalities will be focusing on pulmonary function tests today, because it's not something we oftentimes spend a lot of time on the hospital service. You guys know that, and I'll be referring to that paper I've shown you guys before about just the generalist approach to pulmonary function tests. And that's the reference article I'll be using for this. And this is a direct quote from that paper, of course, using pulmonary function tests to assist in the identification and quantification of respiratory system abnormalities by examining flows, volume, and diffusion. And so really that's, a generalist definition of the role of pulmonary function tests in a nutshell. And this list is not comprehensive, but it is, I think, indicative of a lot of things we can gain from using PFTs, or even point of care office-based spirometry, if ultimately you end up in a practice where that's offered and available. So of course, primary lung issues, where we're breaking the components of the pulmonary function test down into obstructive, restrictive, or parenchymal abnormalities. Looking for neuromuscular weakness, certain cardiovascular processes, anemia, and then potentially following a disease process and response to therapy. And I just wanted to show you this by way of just making sure we're all on the same page when we start to look at some of these sample pulmonary function tests with respect to the terms that we're using. And the main terms that we need to be aware of is this term called vital capacity. On the PFT, it'll also show up as FVC, or forced vital capacity. That's when the patient is at a maximum inspiration and blows out to a maximum expiration, and that's a very important one. Another one that'll come up will be total lung capacity, and then residual volume, and those are the biggies that we'll see on Spiro and pulmonary functions. As we look over on this normal appearing flow loop, expiration, inspiration, we see that the FEV1 is the amount that can be blown out from this maximal inspiration in 1 second. And so the FEV1 is also another very important term. And so I just wanted to make sure we're on the same wavelength with some of these terms going forward. So really from a generalist perspective, kind of an approach to interpreting PFTs kind of involves at least locking away in your memory. And I always have to re-review these every time I look at pulmonary function tests, just so you have a sense when you're looking at the numbers, what's normal. And if you read this paper that I referenced here, different pulmonary function labs will use combinations of different guidelines to get to a normal. But in general, if you go by this criteria, the GOLD 2017, and these numbers are all in percent predicted. So a normal FEV1 to FVC ratio is greater than equal to 70% predicted for that patient. So when we're walking through our algorithm, and the first thing we do after looking at the quality of the flow volume loop is looking toward the FEV1 to FVC ratio. That is the first step at greater than equal to 70% predicted. When we look for obstruction, the severity of obstruction is graded by the FEV1, and it's a volume that's blown out in 1 second from that maximal inspiration point. And greater than 80% predicted is normal or mild, 80 to 50, 50 to 30, less than 30. So that's kind of how we grade from normal / mild all the way down to very severe. And if we go to restriction, the severity of restriction is based on the total lung capacity, or if you have spirometry alone and you don't have the plethysmographic volumes, the forced vital capacity becomes a surrogate for total lung capacity. But remember, it's a surrogate. It's not a perfect mirror. And the FVC is oftentimes not reliable when the restriction is very severe. So if we can lock these numbers away, the FEV1 to FVC ratio, obstruction severity by FEV1, restriction severity by total lung capacity, it helps us then as we walk through our algorithm with these pulmonary function tests to get a sense for kind of what we're looking at, so we can begin to categorize and objectify why our 82-year-old patient, who is a brand new patient to us, has been complaining of progressive dyspnea for at least 6 months, if not more. So how do we approach it? In general, these are the basic steps. I'll show you another kind of algorithm for this, but I wanted to review these briefly, first of all. And that is to look at the flow loops, if they're available. They're not always available. Just to verify technical adequacy, or if the flow loop doesn't look normal, that you have a sense that it's reflecting a good effort and not necessarily is just a bad effort, because of course flow loops can be abnormal for any number of reasons besides just COPD and pulmonary fibrosis. And so that's why we need to look at those loops initially. And then we walk through this process. You look at the FEV1 to FVC. Is it high or normal, or is it low? Then you look for the FVC. Is it high, normal, or is it low? Then the total lung capacity, then to the DLCO. And we walk through in this pattern that allows us then to get a sense for ultimately what we're looking at. Is there obstruction? Is there restriction? Is there a diffusion problem? Is there a neuromuscular weakness problem? Is there an effort problem? All of those things can come to play. And if we end up down the pathway where the result is nonspecific, then if it's available on the test, we can look to the airway resistance. And that you'll see that as the RAW, which is a direct measure of airway resistance, or the GAW, which is an inverse measure. And there's a whole discussion as to why one might be better than the other. For our purposes, bottom line is, if I can, I look to the direct measure just to get a sense for if we can further clarify a nonspecific pattern. And I will say, when you're in the office using office-based spirometry without associated TLC and residual volumes, this nonspecific pattern problem comes up all the time. And so you really need to be careful that you don't overcall restriction based on outpatient spirometry that does not have the associated total lung capacity. I can't tell you how many times I was doing that. I had my office spirometer and I would get a nonspecific pattern that was tending to look like restriction, and ordering high-res CTs to find out everything was okay. And then when I had a sense for that this was this thing called a nonspecific pattern, you can enter into that diagnostically without feeling like you have to go on to advanced imaging to sort that out. So that's the process. And then, of course, just the definition of what is a bronchodilator response. That's when the FEV1 or the FVC improves by greater than or equal to 12% and absolute increase of 200 mLs. So let's go to the next slide here. So before we go to these cases, I just wanted to show you real quick this paper right here, because I look at this paper a lot, and if you guys have worked with me on the hospital service, you know that our quiz questions focus on this. So when we talk about approaching a pulmonary function test for the generalist, and we talk about looking initially at the flow volume loops, here they are, the classics. Normal. Anybody want to take a stab at what this one's kind of looking like? Somebody want to chat in or unmute right here? B. Great. So yeah, that's good. COPD, but let's think physiology for the moment rather than diagnosis. Yes, perfect. So, and would you say mild, moderate, or severe, especially when you compare the one right next door to it? So is B, would you say, which is worse, B or C? Yeah, great. So B is mild, moderate, C is severe. And of course, blue is the effort of the patient, and the yellow is predicted. And so the reason the effort and the predicted are pretty close here, but the difference is the shape. You can see that as they blow out, they're getting to kind of a peak velocity quickly, and then it starts to plateau out, and that's the obstruction right there. And here we've got such bad obstruction that the volumes are being affected to a big degree. Okay, so ABC, so normal, mild to moderate obstruction, severe obstruction. Now we go down to D. Any thoughts? Physiology-wise, yes, perfect, excellent. And so same deal here. Here's kind of mild to moderate, and here's more severe obstruction. So these are pretty classic, and these are all expiratory flow loops. So as you look to see if your pulmonary function test or your spiral, whether you do it in the office on your portable machine, or whether you're getting your report back from the one you ordered from the hospital, ideally, if somebody's normal, you want it to look like this. If somebody's abnormal, you still want it to kind of reflect potentially a pattern. The caveat to that, though, is what if it's really abnormal? So if we go to these next flow loops and we take into account not only expiration, but also inspiration. And I really struggled with these because initially I look at these and I'm saying, well, man, they're all abnormal. Both of those loops are abnormal. But I think when we're looking at the issue of expiratory and inspiratory flow loops, it's kind of the proportionality. So if we look at this one right here, this is it's basically saying that the inspiratory loop is attenuated. Here's one where the expiratory loop is attenuated. Here's one where inspiratory and expiratory is attenuated. So then you think in terms of going back to the diagram F here, when we have an inspiratory loop that's attenuated, the differential diagnosis on that would be a variable extrathoracic obstruction, something like granulomatosis with polyangiitis. If we look here and we look at something where the expiratory loop is very attenuated, but the inspiratory not so much, this is the variable intrathoracic relapsing polychondritis. When they're both attenuated, this is something like tracheal stenosis. Anybody want to take a stab at this one? Where we don't really have an inspiratory, but the expiratory, it's like it starts out okay, but then it peters out, and we don't have an inspiratory to compare to it. Yeah, I would say, that's a thought, obstruction. Another thought would be, how about just an effort? The person kind of just, rather than cranking an effort. The other option here would be muscle weakness, neuromuscular weakness. This one is a normal one, but it's got some sort of a plateau, more of a prolonged plateau, and I don't totally understand the physiology behind this, but it's something apparently that this particular lab sees occasionally. So when we're talking about step one in approaching the interpretation of pulmonary function tests, and we're talking about look at the flow loops from a generalist perspective, this is what we need to have kind of locked away in our mind. And you can see that just because it doesn't look perfect doesn't mean it's a bad test. It really is tech dependent. And I don't know if any of you guys have ever been in the pulmonary function lab when they're actually doing these, but those techs really have to coach the patient and encourage the patient to go, go, go as they blow. Or if you're in your office, you need to train your MAs that they got to do more than just kind of like, blow a little whiff into the thing, but they really got to coach them. You should hear yelling coming out of the room, go, go, go. So we know that it's a good effort and a good test, especially if you're doing this on the outpatient side on your own and you're doing your own kind of quality control, quality measures on this. Okay, so step one, this is step one, looking at the flow volume loops. Now let's look to step next. And I love this table because it puts it all in perspective. And so like I was saying, we examine the flow volume curves and we consider that, okay, we think it's a decent test. Then we go to the FEV1 to FVC ratio. Let's go down the normal or high pattern. Then we go to the VC or FVC. Remember I said on that little diagram that those are essentially synonymous. So if you're normal and you're normal, then you're normal. You can go down here then still and go to the DLCO. If you're normal with respect to flows and volumes, but you're low in respect to diffusion, then you're looking at a pulmonary parenchymal or vascular disorder, and anemia can even sneak in this way too. And that's why I put anemia in our list of things that you don't obviously use a PFT to diagnose anemia, but it can be a suggestion when you're taking this indeterminate patient and trying to begin to sort them out. So if we go again, FEV1 to FVC, normal or high, we go to vital capacity or forced vital capacity low. Then if we've got it, this is where we need to go to total lung capacity. If that's also low, then we've got restriction, and there's where we need to memorize. Remember, our first number we have to remember is this number. You guys remember what this number is? What is normal for an FEV1 to FVC ratio? Anybody want to try to remember? Perfect, 70. And then now we're down the algorithm to low and low. So we're at restriction and we grade severity. And you remember what we use to grade the severity? It is the total lung capacity, or the FVC, and it was 80, 60 to 80, 30 to 60, less than 30. I always forget exactly, but it's that algorithm that then you grade severity. And then you look at the DLCO for diffusion. Low, you've got your classic parenchymal restriction. Normal, then you have to worry about chest wall limitation of some sort. So we continue to walk the algorithm. This time we're normal or high, low, and normal with TLC. This is your nonspecific pattern. This is where you look to that RAW number, and they actually do sometimes report that out on our PFTs. And that's why it's always good to, in the same way, of course, obviously, we need to know how to read our own EKGs. As a generalist, you guys really, and I really need to know how to read a PFT. So it's great that they put that little forward sentence in the report for the result. But really, I mean, you guys should be looking at the data and the numbers, and we'll do that here in a second, so that you get a sense. And if the RAW is high, then that nonspecific pattern moves towards obstruction. If that RAW pattern is low or normal, it moves to chest wall limitation. Then you go to your bugle pressures to kind of confirm or deny what's going on there. And this, you can find ALS this way, guys. This algorithm will lead you right to ALS right down here. All right, so that's the normal to high FEV1 to FVC ratio side of the equation. If we go the other way, low, then we go to vital capacity, forced vital capacity, low. We go to total lung capacity, normal, high, or low. And here's the mixed pattern there, mixed restriction of obstruction restriction. And then you can grade bronchodilator response, look to the DLCO, and this is the classic distinction that you guys are well aware of. If you're coming down the obstruction pathway and you've got a normal or high DLCO versus low, that helps you determine, in addition to the bronchodilator response, you know, if there's fixed obstruction or if there's reactive or modifiable obstruction. All right, so this table is helpful, and kind of lock it away as we go to our cases here. So, all right, let's pause for a moment. You guys with me here? Are we okay? Can we go to try some cases? Any other questions, comments? I know that's a complex algorithm, but it's really not that complex. You only really have 3 or 4 decision points along the way. Okay, so let's dig in. This will be kind of fun. All right. Okay, so I'm going to give you guys a moment to read this, and then we'll walk down and we'll go through these numbers. And again, it's all about the FEV1 to FVC, the vital capacity or forced vital capacity, the total lung capacity, the DLCO, and if they have airway resistance measures on here. I mean, everything else is, to a generalist, it's kind of smoke and mirrors. But if you can lock in to those main components, then we can do this. So all right, so let's say you had a chance to read the stem. Let's go down here. So where do we go first? Out of all this gamish down here, where do we dive in first? Right there. High normal, high/normal, or low? Got to remember that number. Good, excellent. It's greater than or equal to 70, so we're normal. Where do we go next? The FVC. And here's a percent predicted is, and it's 102, so that's normal. And then where do we go next? Total lung capacity, normal. So we got normal PFTs here, don't we? And then you can peek at the DLCO just to make sure you always do it. I don't know, this particular example has so many of them. I just went with the top one. DLCO, 84% predicted. So in that sense, we're good. And all right, so we're all good there. So these are normal. So the question then is, in the setting of these clinical complaints in our dyspneic patient, what would be the next best step for this person? Okay, that's an option. C, okay, that's an option. And so, yeah, you're right. So really, you're making a good point here. As a generalist, somebody coming in like this, the differential diagnosis of this ongoing chronic cough usually ends up being something like undiagnosed asthma, GERD, or postnasal drainage, which they now have a fancier, newer name for, which I can never remember. So sure, I think it would be very reasonable as a clinician to trial a treatment before you actually moved on. The technical answer to this question is probably something we would kind of rarely do in clinical practice, and that would be C. So it does talk about, here it is. It's called upper airway cough syndrome, previously known as postnasal drip syndrome, and GERD. So I think Hannah makes a good point. I think in practicality, you might try a empiric treatment of something before we rush to the methacholine challenge. We don't order a lot of those. I don't think actually I've ever ordered one. The technical answer, though, what they're getting at here is we don't want to miss this whole issue of undiagnosed asthma either. So if they fail the treatment trial of a PPI, that would be the next step too. So those are both of those are reasonable approaches. I mean, I guess really all of them are reasonable approaches. Pick one, try a treatment trial, depending on how sick the patient is and how quickly you need to get to an answer. And then if your treatment trial doesn't work, you can go move on to more complex diagnostic testing. And I don't even know, do we do these in our hospital? I've never really ordered one. Have you guys ever ordered them? No? Okay. All right. So anyways, the point being here, what I wanted to say even more than the STEM was just what does a normal pulmonary function test look like, a normal DLCO? That's kind of, and how to not be overwhelmed by all the data that's been thrown out to you. Just stick with your algorithm, pick out what you need to pick out. And, of course, the pulmonary guys, they do. I mean, they go through this and they have their algorithms that are more complex, but I'm a generalist and I have to find a way to break down some of this into ways and approaches that I can apply to patients that I have to keep a broader differential diagnosis open on. All right, great. So let's go to the next question then.
Dr. Duffy?
Yes.
Really, really quick. When they're talking about the challenge, and I read the answer stem, and I get what they're talking about asthma being episodic, and that just with normal PFTs doesn't mean that she doesn't have underlying disease. But how are you supposed to, accept like a 12% or 200 cc increase with normal PFTs and say, oh, she has a disease? Is it just supposed to be that along with clinical picture, or?
Well, yeah. So that, I mean, and I didn't actually look that up, but that's a good question. And the question is, well, what defines an abnormal methylcholine challenge? We know the bronchodilators improve it. The methylcholine will make it worse. And the question is, how worse does it need to get off of normal in order to prove that there is some intermittent kind of reactive airway issues? So I guess, I don't know if that answers your question, is what is the value of what makes a methylcholine challenge test diagnostic? Would be the opposite of the bronchodilator challenge. It would be a negative response. It would decrease these numbers by a certain degree. And I don't know what those exact numbers are.
Dr. Duffy, I had heard from an allergist here in town that that they don't really use methylcholine challenge practically. They do a trial of therapy to see if they respond.
Right.
I think a methylcholine challenge is very expensive, like over $2,000, but I'm not sure if it's really used practically in an everyday setting.
Yeah, and that makes total sense, and that's why I've never really ordered one, but I think the concept is important, and the concept is that even though she's good in between times, when she gets flared up, and how best to sort that out. So yeah, it's a good point, and so I think all of those are reasonable points. And my main point in this question is, here's what normal spiral looks like in this kind of this setting, just to make it more interesting to look at it. So okay, so any other questions? Thanks for those comments, guys. By the way, excellent. Any other thoughts on this? Let's go to the next one. I got 4 to go through, so we do want to see if we can get through this here. So, All right, does the patient have a significant response to bronchodilator therapy? So before we just go to answer the question, just like we approach an EKG, rate, rhythm, axis intervals, hypertrophy, infarct, let's go to pulmonary functions. And here we go. So where do we start? Right here? Ouch. I mean, where are we at percent here? We're at, she's at 47% right here. So that's low, 47%. Then we go to the next one, which is the FVC, which is 93% predicted. So we've got low, we've got normal, and then we go to the TLC, and we got normal. So we got low, normal, normal. You guys probably don't remember from that algorithm where that puts us, but what's your thought here? What we have before we look at the bronchodilator, before we go to the answer, before we go to the bronchodilator response, what's going on physiologically with this person? Yeah, excellent. So this is classic obstruction. I probably wouldn't add air trapping at the moment, because with air trapping, you're going to need to see, I guess with residual, they didn't give us the residual volume. So you really need to see that. And so with a normal TLC, I would personally just call this good old fashioned obstruction. And I wouldn't say hyperinflation or air trapping, because we don't have enough extra data with residual volume wise, and the TLC is normal. Hyperinflation at TLC would be elevated, and with air trapping, it actually would probably be low, and we'd have a higher residual volume. But so obstruction. So this is obstruction. If you want to clarify the severity, we go in here, and the FEV1 is 56. So that tells us, remember our numbers? I don't remember exactly what were they were. I always remember 60, 80, 30, 60, something in there. It looks at least moderate, and I have to look back at those exact numbers. So now the question is, will this patient respond to bronchodilator therapy? So if we look over post-bronchodilator, and we remember our definition, greater than or equal to 12% plus a 200 ml increase, what would you say? So there's the vital capacity. Not so much, huh? And if we go to the FEV1, it goes from 1.15 to 1.20. What is that? 0.05 liters. So we don't have it. So yeah, that's right. So the answer is no, because there's not at least a 12% increase and a 200 ml increase in either the FVC or the FEV1. Great. So simple obstruction, negative bronchodilator response. This is a fun one. This is which of the following would likely improve this patient's PFTs? Okay, so before I even look at the answers, let's read the PFT. So EKGs are rate, rhythm, axis, interval, hypertrophy, infarct. PFTs, where should we start? FEV1 to FVC. Looks good. Where do we go next? We go to FVC, which is low. Okay, so right there, it's telling us, I mean, it's starting to smell a little bit like restriction, isn't it? But now we go to the TLC, and what is it? It's above 80, so it's normal. And so this is a perfect example of the undifferentiated or indeterminate PFTs. So what would you do next? If you didn't have, if you just, in your own thinking, what would you look to next? Not what did they show us here next, but in your own thinking, what would you want to see next? So this would be a good example of where those airway resistances would be helpful, because if you did an airway resistance and it came back normal or low, I guess, that takes you to chest wall limitation. If it comes back elevated, it pulls you back into potentially obstruction. But we don't have that, do we? So I didn't go over this number, but this number can kind of be a surrogate number, not necessarily for resistance, But for kind of other issues, and look at the MVV here, that's the maximum ventilatory volume. That's when you have somebody huff and puff for a minute and see how much they can do before they get, I don't know, hypocarbic and pass out. But you see it's low. So the MVV is low. So either we got an effort issue here or we got a muscle strength issue here. So we've got undifferentiated PFTs. They didn't help us because they didn't give us airway resistance. And we've got an MVV that's low. Now, does that help you answer the question? Beauty. Yep, Mestinon. That's great. So this would be somebody like with myasthenia. And so it'd be, in fact, I mean, yeah, so that's excellent. One more quick, and then we'll keep moving here. All right. So which of the following is most likely to be present? So this is asking us to interpret these PFTs and associate a pathology and a pathophysiology with it. So again, let's go to our approach, FEV1 to FVC. Normal. FVC is low. TLC is low. DLCO is low. So before you even look at the answers, what is that telling us right there? Beautiful. Restriction. I guess in theory, is it restricted because of a parenchymal process, or is it restricted because of an extrathoracic process? Well, the DLCO helps us with that. So it is a parenchymal process. Now let's go back up here, and you need to know which of these are associated with a restrictive parenchymal process. So everybody's going for A. So A to me is the pathophysiology behind alpha-1 antitrypsin, which to me is an obstructive problem. Traction bronchiectasis. So bronchiectasis in and of itself can be restrictive or obstructive. Traction with architectural distortion, I would lean towards this one. Definitely not this one. And this one, no. I mean, you wouldn't get restrictive PFTs. If you had enough, so this is where your flow loops would be helpful. If you had enough mediastinal lymphadenopathy to really be obstructing your airway, what would you expect to see on your flow volume loops? That first graph I showed you. You'd probably see attenuation of, expiration and inspiration. I would guess. That would be a sense. But it would have to be pretty bad. I mean, this would be mild mediastinal lymphadenopathy. Shouldn't do a whole lot. And so, in this case, it's B. Okay, so this one I just wanted to show classic restriction as a parenchymal process, but keep in your back pocket, if that DLCO is normal, then you got to think about billows and you got to think about chest wall too. So, all right, so those are the 4 examples I wanted to share. Let's jump back into this here. Again, keep rolling through. Okay, so when we talk about the dysmic patient, remember we had the 4 modalities. We've got PFTs, we've got EKG, we've got treadmill exercise test, and we've got POCUS. Okay, so we just got done looking at PFTs. EKGs, you guys have been working on these, and you need to continue to work on them. But my point being here, I just want to reiterate, it's all about the process. So in the same way with PFTs, we're going through the process in the midst of all of that data, pulling out your 3 or 4 important factors. With EKGs, it's all about breaking it down step by step so that you don't get overwhelmed by just looking at all those squiggles in a gestalt fashion. So right near the max interval hypertrophy infarct. That's all I'll say about that for now, but 2 very important tests for the generalist. So when we approach POCUS interpretation, we really haven't talked about this a whole lot, and so I'm trying to kind of put together a process. But if you remember, you probably don't, but as I've kind of shown to you guys the protocol I've put together, I've just called it this exam protocol. It has 7 components to it. But when you think now about trying to focus a POCUS approach or an evaluation towards an individual problem, here we've got dyspnea. So how would we take these 7 components and focus it in on a dyspnea problem? Well, I mean, that's open to debate and discussion, and there's different ways you could stir that, you could make that happen. But generally speaking, looking for abdominal fluid. From a pulmonary side, looking for sliding signs or not of the pleura, looking for A or B lines, looking for pleural effusion, or from the cardiac side, looking for EF, LVH, pleural effusion, or valves in our 4 basic views. So that would be the POCUS approach. And so those, in general. All right. So the fourth, I'm not going to get into today. Treadmill is a whole nother discussion, but it is a great test for that whole issue. Is it heart, is it lungs, is it deconditioning? It's never let me down. It's if the EKG is abnormal, it's the heart. If the SAT's abnormal, it's the lungs. If both are normal and the patient's huffing and puffing, they're out of shape. That's generally, and there are variations and sub details on all of that, but generally speaking, that's the general approach to a treadmill. So let's go to this case, because I thought this was kind of fun. And so we're back then to the case we presented at the beginning. And we've got our 82-year-old coming in with definitely not acute, I would say chronic progressive dyspnea with a SAT of 89. But she's comfortable, she's compensated for the most part. And everything else is unremarkable except for her exam, which showed systolic murmur. You also heard a diastolic murmur. You also saw some lower extremity edema, and you also showed some crackles. So let's start by looking at the EKG first. Does anybody want to go through our breakdown and then tell me in general what you think you're seeing here? So rate, rhythm, axis, intervals, hypertrophy, infarct. Good, sinus rhythm, great. Axis, yeah, perfect, sinus rhythm, right axis. So there you got an issue right off the bat, don't you? So rate, rhythm, axis, intervals. Good, so I agree with you. Those axis intervals look good. Rate maximum is hypertrophy. And don't forget to look at all your chambers for hypertrophy here. This is a classic EKG, a board EKG right here. And it's subtle, and I don't want you to miss. So I guess what I'm saying, before we move on, make sure we look at atrial hypertrophy / enlargement and ventricular hypertrophy / enlargement. Do we see any at all? So far, we've got a right axis deviation, and we're looking at hypertrophy. LVH, I don't think it meets criteria. We don't have the 10 up here. We don't have V1, V2S plus V4, V5R greater than 35. So I would say no on LVH. What about the other ventricle? So P mitrale, you're getting close. So look at here. R greater than S and V1, what's the differential diagnosis for R greater than S and V1? So, all right, so it's going to be posterior infarct, RVH, WPW. So now you do have pretty decent R wave progression, so you don't want to overinterpret that, but clearly there's an issue there. Okay, so we have right axis deviation. We're maybe explaining that by a little RVH, although it's not 100% for certain. But more importantly, what about the other atrium? You said P. What about M? And this is the biggest abnormality on this EKG. Of everything on this EKG, this is the thing that's jumping out most prominently. Yeah, which atrium? Try the other side. Why? No, it's left. Why is it left atrial enlargement? We've got a wide and bifid P wave in 2, but look what we got in V1. Look at that big left atrium right there. So you've got right axis, borderline RVH, and a big left atrium in this patient. Who knows what that means? We have no idea what that means, but this is what you got. And this is classic. This will come up at one point or another. Okay, so we're on point 1 of sorting out our dyspneic patient with this EKG. Now, let's go to our tool number 2, and let's read these PFTs here and see if we can continue to sort this out. All right, somebody do this for me. Somebody unmute. Hannah, you can do this. Unmute it and do it. Or somebody. I don't want to put anybody on the spot, but go ahead and walk us through this. Somebody. Okay, I'll do it. No. Somebody? FEV1 to FVC.
Hello?
That's good.
Hello.
Yes. Go
You're
ahead.
talking about the. Sorry.
How
One second.
to read the spiro or pulmonary function right here.
So first, we're looking at the FE1 to FEC ratio, which looks like it's normal.
Yeah.
Give me 1 second. I think we got rid of the echo. Sorry.
Yeah, good.
So the FEV1 to FEC is at 77, so that's going to be normal. Then we're going to look at the FEV1, which.
I would go to the FVC next.
Oh, sorry, the FVC.
Which is the spiro surrogate for total lung capacity.
Sorry, I can't hear you because I have to have my sound off so I don't echo.
Okay.
But so the FVC is 2.37, so that's going to be normal.
Normal or very close.
And I'm going to look at the total lung capacity, which is at 106, so that's normal. So just reading this is going to be, looking down at the diffusion capacity. And so that's going to be low for that patient.
Yes.
So it doesn't look like there's any obstructive or restrictive processes that are happening, just an issue with diffusion.
Perfect. Excellent read. And so now we've got, can you hear me okay now, guys? I didn't know. Okay, that was excellent. I don't know who that was, by the way, but thank you for unmuting and doing that. That was very good. So now we've got a right axis, a little bit RVH, left atrial enlargement, normal flows and volumes, and a little bit of a diffusion problem. All right, let's go to the next. Now we pull the POCUS out. What organ are we looking at here where my arrow is? We'll start with organ and then we'll go from there. Good, perfect. And what are we seeing on this organ, this lung here? Anybody? Clearly we've got these rockets, don't we? B-lines, beautiful. What is that telling us? Yeah, pulmonary edema, perfect. In this clinical situation, remember our exam? How about this lung down here, or this organ? I gave you the answer. This is M mode on the pleura, and keep this in the back of your mind, what this looks like, because this question will come up in a second. Now let's go over to this organ right here. Anybody, you guys know it's the heart. Anybody want to take a stab at what view? And this is a reasonable view of a POCUS view. So this is for a full-on, full echo. This view is a little bit off axis and it's not perfect, but for a POCUS view, when we're trying to sort this out at the bedside, this is kind of what you would get to look at. And so anybody want to take, well, let's just start first by what view we're looking at. What view is this? Remember the name of the view? Remember our 4 basic views? Yeah, so parasternal long, parasternal short, apical 4, subxiphoid. And I think you guys are getting this is the parasternal long. So then to get our chambers, we've got our LV, we've got our RVC. It's a little off axis. Normally this should be down over here with the apex kind of fading away. So our RV is kind of off this way. We've got our aortic outflow. We can see pretty well for a POCUS image, the aortic valve. We got our LA, and we've got our mitral. And so as we look at this, is there any clues we can get, taking into account, our EKG, taking into account our spiro, and taking into account our history and exam, and then using this POCUS view to give us some more information. So if we're looking at this EF, somebody had said the EF looks pretty good, doesn't it? And you can see that it's coming in pretty well on both sides. So we go from EF to a fusion. Now this is harder because it's off axis. The effusion, if we had one, so this is pericardium right here. So the effusion would be up here, which we don't have. So we don't have effusion. So we have good EF. We don't have a pleural effusion. How about valves? There's really only two we can see here, aortic and mitral. There's your descending aorta right there. Okay, so well, for now, so at this point, keep all of this in the back of your mind. And this is what you're seeing. Now let's move on. Okay, so here's where the rubber meets the road. Which physical exam findings? So based on the exam of this new patient we had in the office, now that we've put together the history, the physical, the EKG, the spiro, and the POCUS lung and cardiac component, which physical exam finding is most likely associated with the cause of the patient's dyspnea? And this is one of these where there might be some that are kind of right, but there's definitely one that is the best answer here based on all of the information. Okay, so I'm not saying you're right or wrong yet. I'm just saying in light of what you guys are typing in here, what's your diagnosis? And remember, congestive heart failure isn't a diagnosis. It's like saying iron deficiency anemia. They're red flags, but they're not the answer. Well, pulmonary edema equals Rales, but lower extremity edema, not necessarily. Okay, so we've got a lot of descriptive, but we don't have a diagnosis. So let's go back and look at this echo again. How many leaflets in a mitral valve? 2, anterior and posterior. How many of those leaflets do you see moving there? And how big is that left atrium? Remember our EKG? So we've got a posterior mitral valve leaflet on POCUS at the bedside in this brand new patient you're trying to sort out that's got some element of restriction of their posterior mitral valve leaflet. And look at that atrium, big. That's right where our EKG. So this atrium is what's making that V1 P wave look upside down and that lead 2 P wave look bifid, this right here. All right, so anybody want to try again on this? You've got a mitral valve that's not moving. You've got a big left atrium. You've got an element of a right axis and some RVH. And I guess to be fair, it's probably even better to throw color on it. So somebody who's really good. So first of all, let me ask you this. Which valve do you think is abnormal? Great, mitral valve. Now, if we were to throw color on it, which do you think the abnormal color would be, blue or the abnormal color would be red. And I'm sorry, I can't throw color on this, but I wish I could. So mitral regurg going away from the probe would be blue. An elevated velocity coming through a pinhole in diastole would be red. There you go. So red is the color, but the murmur would not be systolic. And you have it, we already said, remember, our patient has all these 4 findings. We just have to sort all this out. So let's pull it together. We've got an EKG with right axis and left atrial abnormality, maybe some RVH. We've got a normal spiro from a flow and volume perspective, but diffusion is down. We've got a pulmonary edema on our lung POCUS, and we've got a restricted posterior mitral valve leaflet with calcification on it and a big left atrium on our echo. The one thing that could pull all this together would be diastolic murmur, mitral stenosis. And so that would be the way to pull all this together. And so this is really cool in the sense that this is something with these modalities, as well as our history and physical, how we could have a good sense of what's going on with this patient at first eval after spending a half an hour in the room with them. So what is your diagnosis? I would say mitral stenosis. And the question, this is just a side question. It gets back to that other lung, the M mode on the lung I showed you. Is there evidence for a pneumothorax complicating above? And remember, this is all data coming off your POCUS. This is not data coming from the echo lab at this point. This is data coming from the bedside. Let's go back and take a peek at that. So is there evidence for a pneumothorax complicating the above? Yes or no? Great. Anybody want to say why? Why no? What is this called? What is this? We've got 2 options. We've got seashore, we got stratosphere. And seashore means that the pleura is sliding nicely, that it's not fixed by a pneumothorax. Stratosphere means that there is a pneumothorax at the point of where the ultrasound probe is, because the pleura is not moving. And this one is a seashore. Yeah, perfect. Seashore sign. There's your seashore. If it was fixed and there was a pneumothorax, it would be, those lines would be all the way down. So great. And this is all POCUS. So learning how to read all this is great. And learning how to obtain these images takes practice. And I'm still learning. I'm still trying to practice. I got a new butterfly probe and I'm working with it right now to try to get as good as this. I mean, this is a beautiful POCUS image right here, although it would not be an adequate image for a cardiologist to read off of from a full-on echo lab perspective, because it's off axis and it's foreshortened. But for the job we need to do, to basically see that aortic valve is moving, that posterior leaflet of the mitral valve is stuck, that left atrium is big, we can see it all right there. So that's it. So that's our integrated case. And to me, this is the power of some of these simple modalities that we can use at the bedside. But when we really pay attention to the details, like that big left atrium right there, it really helps us with getting this. So, all right, we're right on time. Any other thoughts or comments? Otherwise, that's all I got for this morning. And you guys have a great day at wherever you're at today. All right, talk to you later. Bye.